Bekle.
Hocam sesimi alabiliyor musunuz?
Evet, biz duyuyoruz şu an sizi.
Çok karnım.
Tamam, ben size
So, dear colleagues, I'm Professor Dr. Alp Burak Çatakoğlu from Liv Hospital and Istinye University. It's a great honor for me to start this first webinar of International Medical Academy of Science, and it's a great pleasure on behalf of the committee to present my bifurcation webinar. So it's a project that has started in Liv Hospital with with our CEO, Mary Stroti, and a very distinguished colleague of mine, Professor Talantbek Batraliev. And it's a great honor to be a part of this. And I hope it will be a fruitful session today, and the cardiology department is going to present you some different aspects of cardiology, and I'm going to start with interventional cardiology. The topic I have chosen was bifurcation lesions, and today we were going to discuss about bifurcation PCI. As you know, it's a great debate which technique to use, whether to advance with a single stent or double stenting, and which technique is better than the other. Of course, there's lots of debates. And as part of European Bifurcation Club, I'm also a member of it, and I'm representing Turkey. And we every year discuss different aspects, whether to make proximal optimization routinely, before finishing the case, whether we should do a final kissing balloon, how we should do, which balloon should we use. So there are lots of questions to ask, and the answers always changes year by year. So I'm open to questions, and in case you want to interrupt me, if you want to take part during this session and want to ask me some questions, if you want to discuss, if you have other ideas, I'm open to discuss. So in my today's topic, I first will start with the basics. I mean the anatomy, the physiology, and some basic concepts. And after that, I will show you some cases. So during the cases, I'm also going to ask you questions. You can ask me questions, and I hope it will be an interactive session. So the bifurcation PCI, I know that the topic is the best practice, but this best practice changes every year. But I'm going to tell you the current state. As you know, when we talk about bifurcations, bifurcation has a fractal design. I mean, the proximal diameter is always bigger than the distal diameters. And as the coronary arteries branches, of course, the diameter decreases. And we have lots of formulas about that, both two-dimensional and three-dimensional. But you know that the Fine formula is the best known formula that shows that the D1, I mean the proximal diameter, is three times the distal diameters of the vessels. Of course, technology has helped us to understand this fractal design more. And with the CT scan, we have lots of data from both healthy subjects and also people, patients who have coronary artery disease. So with the CT scan, we have a model that has coming data from the central line and also from the surface data. And as you see in this picture, we can observe both the left system and the right system, and have many information from this three-dimensional modeling that comes from the CT scan. So what we have learned so far is the left main anatomy has some numbers. And as you see in this diagram, the normal left main has an 8 millimeter square of area in the proximal side. The LAD has a 6 millimeter square, and the circumflex artery has a 5 millimeter square of area in the proximal. So this helps, of course, us to optimize the procedure, because when you finish the case, these are the numbers that you want to achieve. If you have the ability to have an intercoronary imaging like IBUS or OCT, which of course we recommend a lot also as the European Bifurcation Club, to have an intercoronary imaging capability in your laboratory. This could be either an IBUS or an OCT. So from this CT scan, we have also data not only from the left main, but also from the left anterior descending, the left circumflex, and also the RCA. And most of these measurements come from either IBUS, QCA, or CT scan. So the next slides, I'm going to show the results of the CT scans, which show healthy subjects. And as you see in this diagram, most of the healthy subjects have a mean diameter of left main 3.7 millimeters. And the LAD diameter in the proximal part is 3.3. The left circumflex is 3.2. We not only have the diameters, but also the angles. And we have the A, B, and C angles in the bifurcation, which usually we prefer the B angle, which is the angle between the side branches and the main branch. And the left main bifurcation, B angle, is approximately 67 degrees. And these numbers come from healthy subjects, as I've told. We also have data from the left main as a length, and we know that the length is approximately 10 millimeters in the left main in healthy subjects, which is also confirmed by a CT scan. So the normal proximal diameters, as I've shown you before, we have many numbers here in this diagram, and this one shows the LAD proximal, which is 3.3, as I've shown you before. And the circumflex proximal artery has a diameter of 3.2, and the RCA in healthy subjects, it's around 3.4 millimeters. These numbers are important because also when you want to achieve a good results in bifurcation lesions, you have to be aware of the healthy diameters, because when the patient comes with a diffuse coronary artery disease, of course, you may have a mistake to underestimate the diameters, and in case you prefer a smaller stent, a smaller size stent, of course, the underexpansion of the stent will cause you further problems like restenosis or stent thrombosis. So I will progress one by one, and I've started with the left main, and now we will discuss on the LAD and diagonal anatomy. And as you see in this LAD diagonal 1 anatomy, the size of the diagonal branch is around 2.5 in healthy subjects, which is in the main vessel is 3.5 in the LAD. And the angle, the B angle, is usually 49.2 in healthy subjects. And these numbers come from around 300 cases collected data from a CT scan atlas. And this data shows the normal coronary anatomy. And when we come to the circumflex obtus marginal, we see that the circumflex main vessel is around 3.4 millimeter in diameter in healthy subjects, and the obtus marginal 1 branch is around 2.7 millimeters, and the angle is around 51. So when we come to RCA distal, we see that the main branch is approximately 3.6. The posterior descending side branch is around 2.6, and the posterolateral branch is around 2.5 millimeters in healthy subjects. And the B angle is around 57. So when we summarize, the B angle usually is around 50 to 60 degrees in all LAD diagonal, circumflex obtus marginal, and the RCA distal portion. So these numbers help us in choosing our PCI technique, because the size, the angle helps us to understand whether we will lose this side branch or not. So we should maybe start with a 2-stent strategy just before the case. And also these numbers will help us to understand the clinical outcomes. So it is a prognosis parameter. And in case, of course, you finish the case with an undersized stent, that means you will have both acute problems during the case and also some chronic complications during the long-term follow-up. And also this sizing and the normal vessel anatomy is very important for us, because in the future, we will have maybe some more personalized treatments, and the CT scans and the modeling will help us to have an atlas of normal populations. Maybe we should make these studies in different countries also. This is a US-based study, but we should, of course, replicate this study in Europe and also in Asia. We should understand the normal anatomy of the normal population. And this will help us to understand this coronary artery anatomy better. And maybe we will have some 3D printed materials in the future, which will exactly fit the specific coronary disease in this specific patient. As you know, we have lots of classifications for bifurcations, which has started with the Lefebvre classification, but today we're using Medina because it's simple and it's simple to report and simple to remember. But we also have a very current, a very new classification for left main bifurcation, which is the ABC classification. So these were the previous classifications, which were very difficult to remember, as you see in the Lefebvre, the Duke classification, the Sanborn classifications, which has lots of details, the Saffian classifications. And maybe this one was the hardest one to remember, which is the move ahead classification. And it has lots of details like calcification, side branch size, lesion length, etc. But as you see in this diagram, the Medina is the easiest one to remember, and it's also the easiest one to report. And as you know, we give either the number 0 or 1 according to the diseased segment of the vessel. If you have a disease in the proximal main branch, you give the number of 1. If it is free of disease, you give the number 0. So in case you have the disease in the distal branch, the second part of this Medina classification is the distal main branch. And the third part is the side branch. So if you have a disease in both the proximal, distal, and also in the side branch, that means you have a 1-1-1 Medina. If you have only a side branch disease only, then you will have a 0-0-1 Medina. And as you see, that's the easiest classification that you can ever see. We also have another classification regarding the techniques of stenting, and that is the MATS classification. And this represents whether, in case you start with the proximal part of the bifurcation, by stenting or intervening the proximal side, that means you're in the M portion. And of course, in this classification, you see that you can either put a stent across the side branch, you can just start with the distal, or you can start with the side branch like DK crush. And these are all different techniques classified in this MATS classification. So there's, for every class, you have at least one technique. So I also want to summarize the very current classification of the left main bifurcation treatment. And it's very easy also to remember because there are 3 or 4 letters, the A, B, C, D. And in case you have a small vessel, the letter will become a lowercase letter. So I will just show you some examples to make it more easier. And in case you have this disease in the proximal left main and also in the distal part of the main vessel, and also have a disease in the side branch, this is an ABC. I mean, 3 of these branches have the disease. But as you see, the circumflex artery is relatively small than the other branches. So that makes the C letter a lowercase letter. If this circumflex was as big as this LAD, the C would have been an uppercase C. In this example, we have a disease in the left anterior descending ostial. So this is actually a 0-1-0 lesion in Medina, but now we classify it as B, because in the first diagram, the A is the proximal main branch, which is the distal left main. B is the ostial LAD, and C is representing the circumflex. So in this example, this is only an uppercase B. So let's discuss the techniques. And of course, my opinion is we should master in provisional stenting, which is the default strategy in bifurcation stenting. Of course, we should know the two stent strategies. And in my case, you should master at least two different methods, two different techniques in two stent strategies. You should be aware of all the details. But of course, I have to insist on this default strategy that it should be the provisional strategy. And in this slide, I have summarized my 1 year experience. And as you see, if you have 300 cases a year, PCI cases a year, approximately 15% of your cases will be bifurcations. And in only of these 15% of bifurcations, the 10% will have an important side branch, which is more than 2.5 millimeters of diameter and which is longer than 5 millimeters. So that represents approximately 4 cases a year that you should do with two stent strategies. So most of your cases, I mean the 295 cases will be done with a single stent, but only 4 cases will be done with two stents. But that doesn't mean that two stent strategies are not important. They're important, but you should know every detail of this provisional stenting in bifurcation treatment, because if you finish the case perfect, of course, the long-term follow-up will be perfect. So this is a representation of the step-by-step approach of provisional stenting, and it starts with two guide wires. I mean, you will always start a bifurcation case with two guide wires, and never miss the side branch by just trying to finish the case faster, because in case you lose the side branch, it will cause you more, you will lose too much time just to rescue that side branch. So it's a good option to start with two guide wires just to protect the side branch. Because in case you lose the side branch, you have the guide wire there, and you can still use that guide wire, or you can use that guide wire as a guide to rewire with a third guide wire. So you should start with two guide wires. After you put the stent to the main vessel, you should still, the side branch guide wire should stay there until you finish this pot and rewire the side branch. So the third part is the pot, the proximal optimization, which is a very important step in provisional stenting, and you should never advance the case without doing this initial pot, because I will show you later what this can cause. So after this pot, you will rewire the side branch with a third guide wire, and after that third guide wire, you can just retrieve your initial side branch wire, and it will not cause any problem to have your guide wire under the main vessel stent, because it will be very easy for you to retrieve the first guide wire. So after this rewiring, you will do a balloon angioplasty in the side branch. You can do a balloon angioplasty in the side branch if you have a problem in the ostial part of the side branch. But in case it's clean, I mean, if the side branch is open, if you have timid tree flow, or if you have the ability to measure the FFR and it's normal, you can just leave the case after this pot. But if you have to continue to the side branch, if there is some carina shift in the side branch, of course you can rewire the side branch, and after that rewiring you can retrieve the initial guide wire. You can balloon the side branch to a kiss, but in case you make an intervention to the side branch, you always have to return to that pot step, because there will be a deformation just in front of the side branch, which will cause stent thrombosis or restenosis in the follow-up. So I will show you, these are very special images that is coming from the Visible Heart laboratory from Minnesota. So there is, you can see just inside the vessel, and I will go step by step. So it will be a slow advancement of slides. So here you see that both branches are wired, and after that wiring, you insert a main branch stent and implant it on the main vessel. In this case, there's a 3.5 to 26 onyx resolute stent, and the stent is inflated. As you see, the side branch stent is just under the stent. And as you see, there is still some gap in the proximal part because you always choose the stent according to the distal reference diameter. So usually if the distal reference diameter is at 3.5, the proximal will be around 3.8. So you need to optimize this proximal part. Otherwise, you will have difficulty in just opposing this proximal part, and that will translate to stent thrombosis or restenosis in the future. And sometimes you have it in the acute, just in the following hours. So in this case, the operator just tries to advance a third guide wire, and as you see, the guide wire can go just underneath the proximal stent, which will cause a terrible stent malformation, just in case you just advance the guide wire from a wrong strut. Of course, it will result as a disaster. So this is just the proof that you will have problems in case you do not make the pot. And on the left side, you will see the angiographic view in which the operator has difficulty in advancing the guide wire, but he succeeds. But unfortunately, the guide wire goes just under the proximal strut of the stent. And in case you advance a balloon or a stent from this wrong strut, as I've said, it will result in a disaster, and your procedure will become longer and longer just to solve this complication. But after you put the main vessel stent in case you make the proximal optimization, it is very easy for you to advance the guide wire to the side branch and continue the procedure. Here you see a balloon which is a 4.0 to 12 millimeters of a semi-compliant balloon in the proximal part, which makes the position of the proximal main vessel perfect. So it is opposed perfectly, and you don't have the chance to have your third guide wire to go under this proximal stent. So now the rewiring is made simple just by a simple proximal optimization, and as you see in this visible heart model, the third guide wire will advance to the side branch quite easily. Another tip and trick is to advance this third guide wire from the distal strut, which will help you to make the case perfect, because this distal strut will make the proximal stent open just across the side branch, and of course it will result in a better apposition of both the proximal and the distal part. So after you do this rewiring, you can do a kissing balloon. Of course, this is just according to the operator. It's not a requirement, because if the side branch, if you didn't lose the side branch and you don't have to do any further standing to the side branch, the proximal optimization is enough to finish the case. But if you have to advance to the side branch, to make a kissing balloon is simple by just inflating the balloon in the main vessel and the side branch. Of course, the sizes that you will choose is very important. And in case you make a side branch ballooning, it is recommended by the EBC to finish the case with a final pot. Some call this a repot, some call this a final pot, but the EBC now calls this as a final pot. So after you do all these steps, I mean the main vessel stent, pot, and in case you need a side branch balloon or a kissing balloon, finish the case with a final pot, a perfect apposition is accomplished, as you see in the visible heart model also. So provisional is default because you can always put a second stent when you need it. You can advance with a tap stenting, you can make a reverse crush, you can do a culotte. So you have plenty of options. In case you just start the case with a provisional stenting, you always have the option to advance to a two-stent strategy. But the reverse is difficult. I mean, if you just started the case with a two-stent strategy, it is very difficult to finish the case with a single stent. So provisional should be default. This diagram shows the tap stenting, in which you put the main vessel stent and optimize it. You put a second stent to the side branch just with a minimal protrusion to the main vessel, and you make a kissing balloon after you implant the side branch stent, which should be a minimal kiss, a mini kiss. You shouldn't advance both of the balloons just to the start, to the proximal part of the main vessel, because we want to finish the case with a circular anatomy. We don't want to finish with an elliptic deformation. So in case you make the kissing balloon standard way, not the mini way, you should finish the case with a final pot. But of course, the very important trick here is to choose a smaller pot balloon, and the pot balloon marker should never advance to the carina because there is a minimal protrusion here. And in case you advance this balloon more distally, you will finish with a crush of the side branch stent, which we don't want to see. And in case you, by mistake, you make a distal proximal, a distal inflation of your balloon, you should change the strategy. Maybe it should turn to a reverse DK crush or something else. But to avoid this, you have to inflate the balloon in the proximal parts. So now I want to just advance these slides to come to real examples, And this is one of my patients, which is a 61-year-old male patient who had stable coronary disease. He also had hypercholesterolemia and a syntax score of 44, which means, of course, bypass surgery. But the patient refused bypass surgery, and he wanted to have our opinion whether we should continue. We could continue with a stenting procedure, and we had the opportunity to have to advance with PCI. This patient had a lesion in the distal left main, in the circumflex ops marginal portion, and also in the LAD. He also had a disease in the RCA, which is a CTO, but the right coronary artery seems to be a small vessel. So we concentrated on the left system, and we started with the ops marginal, and we pre-dilated the ops marginal with a 2.5 millimeter balloon, as you see. And after this pre-dilation, you will see the result, the control image. After that, we have chosen a long drug-eluting stent, which is a 2.75 to 38 millimeter drug-eluting stent, which was implanted to the ops marginal at 20 atmospheres. And I want to take your attention to the two guide wires. There's always a second guide wire on the main vessel. Because in order you have a problem in the main vessel, this guide wire will guide you and help you to solve the main vessel problem. After we have implanted the side branch stent, we post-dilated with a 3 millimeter NC balloon at 24 atmospheres. And you will see the result of the ops marginal, which was quite good, with a symmetry flow, and the main vessel was clean. There was no carina shift or any other problems, and we didn't take any other steps for this circumflex artery, and we continued with the LAD and left main. Here you see the pre-dilation with a 3 millimeter balloon of the LAD, and I also want to take your attention that we have a guide wire on the diagonal branch. And after that, we implanted a stent to the LAD proximal segment with a 3.5 to 28 millimeter of drug-eluting stent. This was the result. This stent was placed on the LAD proximal, and we still had the problem in the left main distal. So we have chosen a 4 to 23 millimeter of drug-eluting stent for the left main. And it was implanted. And after the implantation, we made a proximal optimization with an NC balloon, which was 4.5 in diameter. And because it was a left main disease, at that time, my recommendation was to make a final kissing balloon in every left main patient. Either he didn't have any problem in the side branch also, because some bench studies have shown previously that it had an advantage in the side branch regarding the blood flow and the fluid dynamics. So in every patient until 2020, I was just making a final kissing balloon to the main branch. But now I'm not making a final kissing balloon routinely in left main bifurcations. So after this kissing balloon, which was a mini kiss, the result was okay for me. So this example has shown us that also in very complex patients that needs surgery, you can finish the case with provisional stenting. So you don't need to put 2 stents in every bifurcations. And as I've mentioned before, only four patients among 300 patients needs a 2-stent strategy. So in this case, you see in different angles that the left main, the obtus marginal, and the LAD was treated with stenting. We have plenty of 2-stent techniques. The mostly known ones are the culottes, the DK crush, the TEP stenting, but we also know we have some less known techniques, the inverted provisional, the highway technique, which was invented by me in 2009, the balloon trap, the slipstream, nano crush, flower petal, V-stenting, or simultaneous kissing stenting. It's a long list. But in my opinion, these 3 techniques and the provisional technique will be enough for you to treat maybe most of your patients. So there is a stenting technique which is not mentioned here in the slides, which was just invented this year, and it's called a DK culotte technique. So I'm going to show you first on a real example. This is a 53-year-old male patient, which is a stable coronary artery disease patient. He has diabetes and hypertension, and he had a previous drug-eluting stent. So you will see this coronary angiogram of this patient. This is the RCA. It seems to be open. And you also see the left system, the left main, the circumflex artery. There's an intermediate artery, which is also quite large with a stent inside, and also an LAD. So our plan was to wire 3 of the branches to treat the left main disease. We wired the circumflex, the LAD, and also the intermediate artery. We use a 7 French radial access and a 7 French extra backup guiding catheter to treat this vessel. So how is a DK culotte performed? A DK culotte is nearly the same as a culotte stenting, but it has an extra kissing balloon step, which I will show. So we will start with a side branch stenting first, and after the side branch stenting, you make a pot to the proximal main vessel, and after that, you rewire the side branch and position your balloons to the side branch and the main vessel. And then you inflate it. I mean, you make the first kissing balloon. After that, you insert your main vessel stent and you implant it to the main vessel. Then you make a pot again to optimize the proximal part. And after that, you rewire the side branch and the main vessel and make a second kissing balloon. And you finish the case with a pot again. So this is the DK clot. What is the advantage? The advantage is shown in a bench test of 24 models, and it was compared with DK crush and with the standard clot. And it was seen that it was a more faster procedure, the DK clot, compared to DK crush or a standard clot. And the fluid dynamics were better than a standard clot, and the standard position was better. In this diagram, you can see the detailed information about the results regarding the position and also the fluid dynamics of this DK clot technique. So how we achieved the DK clot technique in this patient, we inserted our initial stent to the circumflex and dilated with a 3 millimeter balloon at 16 atmospheres. And then we have implanted a 3.5 to 18 millimeter of resolute onyx drug-eluting stent to the circumflex. So this was the first step. After that, we have done a 4.5 millimeter NC balloon proximal optimization. And then we have done our first kissing balloon. After the first kiss, this is the result. Now we have implanted a 3.5 to 22 millimeter of resolute onyx stent to the LAD, from left main to the LAD. And we have done a proximal optimization with a 4.5 NC balloon. And after the proximal optimization, you will see the results. So both the LAD and the circumflex arteries were treated. So after this implantation, the patient had some chest pain and it just began to progress just a couple of seconds later. And we have seen that we are going to lose the intermediate branch, which was the cause of this chest pain. And here we have seen that we have lost the intermediate branch just a couple of seconds later. But for sake, we had the guide wire there. And we tried to advance another guide wire to the intermediate branch. And we succeeded in rewiring this intermediate branch, and we pre-dilated it with a 1.5 millimeter of balloon, just right at the ostium of the intermediate artery. And then we advanced the 2.5 millimeter of balloon to the intermediate artery and dilated it there. After that, we made a kissing balloon with a 2.5 millimeter at the intermediate artery and 3.5 millimeter in the circumflex artery. And then we have implanted a 3 to 18 millimeter resolute onyx drug-eluting stent to the intermediate artery. And in this in this image, you see that we have parked a balloon to the LAD branch. Then we have made a kissing balloon with a 3.5 millimeter of balloon in the LAD and a 3 millimeter of balloon in the intermediate artery. And the final step was a triple kissing, which was done with a 3.5 millimeter of balloon in the LAD, a 3 millimeter balloon both in the intermediate and the circumflex arteries. And finally, we finished the case with a 4.5 millimeter of NC balloon by making a proximal optimization at 30 atmospheres. So this is the result. And as you see, all of the branches are in good shape. The left main, the LAD, the circumflex, and the intermediate artery. So maybe we can stop just here. And I want to ask if you want to to participate. If you have some questions regarding this case or regarding the data that I've shared with you. So maybe we can discuss. I can wait for 1 or 2 minutes. If you have questions, I will be pleased to answer them. If not, I'm going to continue for the next 15 minutes. I'll just show you some tips and tricks and maybe 1 or 2 more cases, and I'm going to finish the session. So if you have any questions, we will be pleased to answer them. So there's a Q&A button just below if you want to write your questions. We also have the raise hand opportunity. If you want to show yourself and ask your question face by face, you can take part. So it's up to you. So I'm going to continue, and in case you have the questions, I'm going to stop and answer your questions. So this part is a very important tip and trick. As you know, if you put the stent to the main vessel, and in case you have a balloon dilatation in the side branch, you will always finish with a side branch with a main vessel stent deformation, which is very, very important, because in case you don't deal with this problem, it will end up with stent thrombosis or restenosis, and stent thrombosis is sometimes very dramatic, which happens just in a couple of minutes or in a couple of hours. This is another trick. You always have to choose the distal side branch to have a better result. To rewire the guide wire, you need to choose the distal strut, because in this image you will see that in case you prefer the proximal strut, there will still be some deformation and the proximal covering of the side branch will be incomplete. But in case you prefer the distal strut, which is not an easy step, and it requires some, of course, experience, and in case you, of course, have OCT or IBUS, you will see it online live, whether you're on the right strut or not. But if you choose the distal strut, of course, you will have some proximal covering of the side branch, and this will make the procedure perfect. The elliptic deformation is another deformation that we see in bifurcation treatment, and this happens when you choose to make the kissing balloon in a classic way, which was done previously. And the classic way is to retrieve the balloons, to cover all the proximal part of the stent in the main vessel. And in that case, of course, you finish with an elliptic deformation. But if you do this with a mini kiss, if you just retrieve the balloons minimally to the main vessel, you will have the elliptic deformation only in a smaller part. And you can, of course, finish the case always with a final pot, which will correct this elliptic deformation and return to the circular anatomy. So this is a 3D OCT representation of this elliptic deformation. In the upper part, you see the minimal overlap with the pot, which results with a circular anatomy. But if you do the kissing balloon with a classic way, of course, you will have some elliptic deformation in the proximal segment of your main vessel stent. There are lots of studies just to compare whether this is very important clinically or not. Of course, we don't have very strong data that this elliptic deformation causes late restenosis or stent thrombosis. There is no strong data about that. But we have lots of bench tests which show that the shear stress and the fluid dynamics is better when you finish the case with a circular anatomy. Of course, to achieve this perfect result, the best practice, it's also important to understand which balloon size you should use. And in our cath lab, we use this diagram because it's difficult to summarize. But this diagram shows you which size of balloon you should choose in the side branch and in the main vessel when you make a kissing balloon. So now we have lots of examples, and there's a long list, but we have only 10 minutes to go, and just going to choose maybe one or two of them. So there is a question, of course. Dr. Omurbek Uraimov wants to ask a question. Sure, you can either take parts or you can write your question. Until the question comes, I'm going to advance with the cases. So in this diagram, we have lots of cases. Now I'm going to maybe choose a DK crush, which is a more complicated case. And after that, we can return to a provisional case, maybe again. So this is a DK crush example. In this example, we have a 56-year-old male patient, which had a non-ST elevation MI. And as risk factors, he had hypertension and hypercholesterolemia. And here we see a critical LAD diagonal lesion, which is nearly subtotal, and it's a 111 Medina lesion. Just want to make the videos work. So I need a couple of minutes. Okay, so there's a problem with the video. So maybe it's better to discuss after that. We have, of course, lots of tips and tricks. Maybe the next time I'm going to show you more examples regarding the practical approach, my own approach, and the EBC recommendations. And it's very difficult, of course, for me just to summarize a very hot topic in just 1 hour. But I hope we will meet again during this Contemporary Medical Academy of Science meetings, and I hope we will have some time to meet also face to face and to have these educations together, because I believe that we have lots of things to learn from each other, and this was, of course, my part to just summarize my own opinion and some opinions from the EBC. But I would also like to learn your approach and your tips and tricks, because we have lots of things to learn from each other. So I have seen the question from Dr. Ömerbek, and he says, thank you for your perfect presentation. Thank you very much to be a part of this. Our team from Kyrgyzstan wants to thank you. And the question is, which technique has better long-term results? So that's a very good question, and we're discussing a lot on this topic in the EBC meetings. And of course, the Asian colleagues from Korea have done lots of researches on DK crush, and they're performing this DK crush technique perfectly. And of course, the results are quite good compared to Kilot technique, to TEP technique, or other techniques. There's also some debate whether DK crush is better than provisional stenting, because some recent papers have shown that DK crush is better than any technique. But of course, there are some bias on this, because the group that is making these researches and writing these papers are all from Korea, and they are, they are mostly oriented to this DK crush technique. And when you read the papers of DK crush 5 or some other DK crush papers, you see that the procedure is standardized, as I've told you in this presentation. I mean, the DK crush has some steps, and the committee is just looking after whether the operator is doing the DK crush as in the protocol or not. But the other techniques like culotte, TEP, or provisional stenting was not described in detail, and the committee is not just looking after whether the operator is performing the case perfectly as in protocol or not. So when you compare two strategies, the DK crush, which is done perfectly by Korean colleagues, and the other techniques like provisional or culotte, which is usually preferred by European or US colleagues, then of course DK crush just results with better outcomes. But of course, this is a point in which we have to discuss in detail, and it's really difficult to answer today because we have no answer for this question exactly. But according to papers and to the data that comes from Korea, DK crush is better than other techniques. And in case you need to choose a two-stent strategy, DK crush seems to be a good alternative. So that's the answer of mine. So any other questions? Okay. So today we have other sessions that will cover imaging, and also that will cover some aortic disease, aortic stenosis treatment with TAVI. And I hope you will enjoy the other sessions also. Of course, you can contact me whenever you want, and we can talk on email or on phone or by Zoom whenever you want. And it will be a pleasure for me to collaborate, to interact with you, and to learn much from you. So thank you very much for attending this webinar. I would like to thank on behalf of the founders of International Academy of Contemporary Medical Academy of Science, and I hope to see you soon, face by face. Goodbye.
My dear colleagues, I am Tuğba Kemaloğlu from Turkey, and it's a big pleasure for me to make this presentation in such a great organization. Today, my topic is Never Without 3D. It's my professional passion, and I feel so much lucky to tell you my experience about it. My presentation will take about 15 minutes, and I will summarize what is the incremental value of 3D over 2D echo in valvular disease, left ventricle assessment, right ventricle assessment, and finally, congenital heart diseases. At the end of my presentation, I will tell you a short story as a take-home message. I am the coordinator of International Young Academy, and despite our association is very young, only 21% of cardiologists use 3D echo in their clinical practices. Only 1 in 5 cardiologists use 3D echo, which is very, very low rate for this century. Please take a look at these two images. The image on the left side taken in 2011 and the other in 2021. Please compare the temporal resolution and take a look at incredible progress in the last 10 years. All mitral valve disease can be assessed more comprehensively by 3D echo. We can explain pathology of valve disease and mechanism absolutely better by 2D. Also, if we understand the cause of disease, we solve it easily. So 3D is the key point for mitral valve assessment and very easy to take a good and face view of valve disease. And impossible to do this procedure like mitral clip, mitral valve repair, paravalvular leak closure without 3D assessment. This is another new technology, that TrueView technology, and on the left side, you can see the perforation of mitral valve anterior leaflet, and on the right side, it's very easy to see the angle of our devices and any motion of mitral clip devices. This is another procedure, which is the paravalvular leak percutaneous closure. And there is a paravalvular leak at 12 o'clock position, and it's very easy to see catheter and device at the 12 o'clock position. Additionally, the new 3D technology let us to take 3D transthoracic view as much as TE quality. And we couldn't understand the cause of mitral regurgitation without 3D in this case, because this patient has mitral valve cleft. Another good news is about a tricuspid valve. Before 3D echocardiography, I was thinking that tricuspid valve has 3 leaflets, but unfortunately not. I know that every patient has totally different tricuspid valve, and mostly doesn't have 3 leaflets. The tricuspid valve on the right side consists of 5 leaflets. However, other has 3 leaflets, and as you see, posterior leaflet is very, very small and teeny. We don't mind tricuspid valve as much as mitral valve. It's also so much important, and good news is transthoracic echo is really very enough for evaluation of tricuspid valve. If we understand the valve completely better than a surgeon, we find the right treatment option. Also, there are many percutaneous treatment strategies for tricuspid valve, as annuloplasty devices, coaptation devices, heterotopic valves, percutaneous valves. Yes, as you know, we can get a face view of aortic valve by 2D echo, and as you know, 2D resolution is still better than 3D. For this reason, the contribution of 3D echo to aortic valve disease assessment is limited. However, 2D underestimate aorta diameters, and correlation between 3D and CT is still very good. Especially 3D plays an important role in measurements of aortic valve, aorta, and aortic annulus. Additionally, 3D echo is very important for patient selection and valve selection before TAVI procedures. 2D echo underestimate left ventricle outflow tract area and aortic valve area by about 60%. We should choose the most suitable valve and most suitable patient. Actually, I would like to shortly touch the pulmonary valve. It's my favorite one, and especially 3D echocardiography plays an important role in evaluation of pulmonary valve disorders. Pulmonary stenosis severity is classified according to transpulmonary pressure gradient and maximal velocity. Actually, I think it's not enough. The pulmonary valve area can't be calculated by planimetry using 2D echocardiography and conventional techniques because the end-phase view of pulmonary valve is generally unavailable. If there is stenosis, pulmonary valve can be visualized better because the valves are usually thicker than normal leaflets. It's possible to see end-phase view of pulmonary valve and detect of leaflet types. Additionally, it's possible to measure the valve area, remote area, and using 3D echocardiography. As you see in this case, I calculated pulmonary valve area and subvalvular stenosis. The peak gradient and peak velocity of pulmonary valve can be affected by many situations as other valves, like pregnancies, left to right shunts, pulmonary regurgitation. And they may lead to misclassification of pulmonary stenosis severity and also may influence the accuracy of the time and necessary treatment strategies. Additionally, 3DT can change half of pulmonary stenosis patient treatment strategy in our study. Not just TE, also transthoracic echocardiography is useful when there is a good acoustic 2D window. As in this case, you can see 3 leaflets of pulmonary valve clearly. What about left ventricle volumes? Of course, echo is more widely available than MRI. And from just the 4-chamber full volume data, all volumetric analysis can be done. We can't do segmental analysis at the same time. Especially oncology patients are very sensitive and important group. Small changes in ejection fraction or strain parameters by 3D echocardiography may lead to change or stop the chemo treatment. Also, intra-observer and inter-observer variability is better than 2D echocardiography. Now, we are able to obtain 12 separate sections from a single image using multi-slice button. And it's very useful during stress echocardiography. However, we are capable to evaluate each left ventricular segment separately to analyze. This is not enough, and we are going more. We want more. The new technology is developing with the speed of life. On the left side, it's not moving, okay. On the left side, the new ecosystem allows us to analyze all chambers, 4 chambers very easily. And on the right side, you see my patient is playing his left ventricle 3D printing model. I believe in that. We will be able to produce our own artificial heart in the future. Yes, what about our forgotten right side? We have more information than just TAPSE and right ventricular S velocity. All right ventricle volume analysis and ejection fraction calculation can be done using 3D and TomTec technology. As you know, 4 years ago, American and European societies published an expert consensus about 3D echo role in congenital heart diseases. It's very useful guideline, and there are strength of recommendation about all congenital heart disease. I would like to share my patients with you, and this is on the left side you see a followed tetralogy patient, and tricuspid leaflet can be seen easily on the left side. Another patient has muscular ventricular septal defect, and you can see when it's closed and open systole and diastole. Not just this type of disease, also any defect can be detected by 3D echocardiography. It's another important patient. This patient has aortic right ventricular fistula, and we use 3DT to measure the defect size, as you see in this image, and close with it suitable and the best device, and you can see the result. There is no any residual shunt. Now, I would like to finish my presentation with a very important and short story. As you know, Nokia has been a respectable and successful company and was the best one in this field. Nokia CEO ended his last speech saying that we didn't do anything wrong, but somehow we lost, and teared sadly. Yes, they didn't do anything wrong in their business. However, the world changed too fast. They miss out the changing, they miss out learning, and they miss out catching the technology. Not, not only they did miss the opportunity to earn big money, they lost their chance of survival. There is a big lesson in this story for all of us. If our thoughts, mindset, and skills can't catch up with the time and technology, we will be eliminated. Thank you so much for your attention, and you should know that we are always ready to collaborate with you as Istinye University, Live Hospital, and International Young Academy. Thank you.
Hello, colleagues. I'm Dr. Ebru Özenç from Liv Hospital Ulus. I'm cardiology specialist, and I would like to present to you about coronary CT angiography today and their use in clinical practice. And coronary CT angiography is a widely used applied technique nowadays. And recently, in clinical practice, we really perform coronary CT angiography as a diagnostic modality for evaluating the coronary arteries. In 2003, the coronary CT angiography started with 16 slide CTs, and today it's 512 slice CTs, and the image quality has increased a lot, and so we can visualize the coronary arteries, and the diagnostic utility is really increased, and so we can a perfect diagnostic utility, and we can do visualize the coronary arteries in a perfect manner. Actually, minimum 64 slice CTs are needed for coronary artery evaluation. And to minimize the cardiac motion artifacts, it's performed with simultaneously with ECGs. And so two techniques are applied in coronary CT angiographies. One is prospective ECG triggering, which is evaluated during mid-diastole or end systole. And we can take the portion of the mid-diastolic or end systolic phase, in which the motion artifacts are minimized. So prospective ECG triggering is the period, is the diagnostic modality that cardiac artifacts are minimized. And the other one is the retrospective gating, and we can take the minimum motion phase in the whole cycle. And so the whole cycle is taken, and the minimum motion phase is taken to evaluate the coronary arteries. As you know, in coronary CT angiography, the CT is performed, and intravenously, the contrast material is given, and later on, we evaluate the coronary arteries with this contrast material, and we can see right coronary artery, left anterior descending artery, and circumflex artery, and also left main artery. And the diagnostic accuracy is about 95% to 99%. Of course, some other factors also affect the image qualities, which I will mention in the following slides. The major concern is about coronary CT angiographies is of course, the radiation doses. But as you see here in this slide, in chest X-ray, it's about 0.1, but in the coronary CT angiography, in males, it's about 7, and in females, because of the breast also, it's about 8 to 30. But with the advanced techniques performed in the coronary CT angiographies, especially it's about the machinery concerns. With the 512 slice CTs, the radiation dosage is really decreased to about 5. And during coronary angiography, of course, it's about also 5. But with performing the stenting and the PCI during the coronary angiography, the radiation doses increases. But some factors also affect the radiation dosages in coronary CT angiographies. For example, if the body weight is increased or the heart rate is increased, if there is arrhythmia, then the radiation dosage increases during coronary CT angiographies. So we take some precautions to prevent the excess radiation. For example, we can give beta blockers if the heart rate is high before coronary CT angiographies, and by decreasing the heart rate, the radiation dose is decreased and the image quality is increased. So the high body weight is also other. For example, 10 kilo increase can increase also the radiation dosage about 10%. Where we apply the coronary CT angiographies, there are heterogeneous clinical tables, of course, and a diagnostic utility should have a diagnostic performance, prognostic performance, and also predictive value. The sensitivity is about 90% to 95%, and the major importance of coronary CT angiography is its negative predictive value. It really has high negative predictive value. And the most important information we get by the coronary CT angiographies is its anatomical evaluation feature. And but it doesn't give information about the ischemia burden of the coronary arteries. So after anatomical evaluation by a coronary CT angiography, we should also do some functional tests to understand, to have idea about the ischemia burden of the narrowings or the occlusions. By the performance of the coronary CT angiographies, of course, invasive coronary angiographies and revascularization rates have increased because more anatomical evaluation lead to coronary angiography performances, and so revascularization, increased revascularization is seen. But does it provide us mortality benefits? There are some concerns about the mortality benefits. As you know, in especially coronary artery disease, stable coronary artery disease, the mortality benefit is provided by revascularization or not is has some questions. But the most important benefit is the primary preventive strategies, because it is the most important thing. Primary prevention in cardiology is really important, and in clinical practice, when a patient is evaluated, we get the clinical history, and later on we do the anatomical diagnosis, and if there is any anatomical narrowing or occlusion, we should perform functional evaluation to understand the ischemia burden for revascularization, before a revascularization, of course. In clinical practice, there are some major topics that we do coronary CT angiography. The most important topic is stable coronary artery disease exclusion, diagnosis especially. And in the guidelines, coronary CT angiography has a value, has a place as a class 1 indication, especially in this topic, because in low to moderate probability risk of coronary artery disease and new onset ischemic symptoms is an indication for coronary CT angiography. The other indication is low to moderate probability risk of coronary artery disease and new onset low ejection fraction heart failure. And the other one is moderate probability risk and before a non-cardiac surgery. And so in these situations, coronary CT angiography has a high negative predictive value. So we can rely on coronary CT angiography for this topic. And but of course, as we all know, if there is high probability risk, coronary angiography, invasive coronary angiography is the first line diagnostic modality for us. But in low to moderate probability risk patients, coronary CT angiography is reliable. The other clinical scenario is in acute coronary syndrome suspicion, especially in the emergency rooms, to rule out acute coronary syndrome, we can also perform coronary CT angiography, especially when a patient comes with a chest pain and the patient has low to moderate probability risk factors for coronary artery disease, and the ECG is normal or non-diagnostic, and the serial enzymes are normal, we can perform coronary CT angiography, and in a negative result, the cardiovascular event risk is under 1%. So we also call it triple rule out in emergency rooms, the coronary CT angiography performance. We can rule out pulmonary embolism by a CT, we can rule out acute coronary syndrome and aortic dissection. And so it's also has a good place in emergency rooms to approach acute coronary syndromes. And the other important area that we perform coronary CT angiographies are coronary plaque evaluation, which has prognostic importance. Why it's prognostically important? The plaque calcification gives idea about acute coronary syndrome risk, because plaques can be classified as calcified, mixed, or non-calcified. A non-calcified plaque can be lipid-rich or fibrous plaque. And we know that the lipid-rich plaques are more prone to acute coronary syndromes, and fibrously rich or calcified plaques are more frequently seen in stable coronary artery disease. And so especially the soft plaques rich with the lipid are prone to acute coronary syndrome, and they're fragile. And so effective calcification on plaque stabilization is a gray area, but we know that soft plaques are more fragile. So in primary prevention strategies, if we see plaques, especially the soft plaques, we should start aspirin or statin. And we use, in my daily practice, when I see a soft plaque, especially in a young patient, I start to use statin and aspirin for primary prevention to prevent the acute coronary syndrome risk. Here is a figure that shows an acute coronary syndrome plaque in coronary CT angiography, which we call napkin ring sign, which shows that the hematoma area inside a plaque, which the patient had the acute coronary syndrome. So it is called in the cross-sectional area of the plaqued area, it's napkin ring sign, which shows the hematoma, hemorrhage inside the plaque, which is seen in the acute coronary syndrome because of the tear in the plaque. And also the narrowing of the coronary artery. And in the left side, we see the non-calcified plaque, which is seen more black inside the narrowed area. And in the right side, it's the brilliant white area that shows the calcified plaque. The other important topic is the coronary anomalies diagnosis. It's important because sudden death is something we've seen in especially young patients, sportsmen, and there is coronary anomalies in most of the young patients, especially the sportsmen. And there can be, the coronary anomalies can result because of the original course or termination anomalies. And there's 1% risk of sudden death according to the coronary anomaly type. The most frequently seen coronary anomaly is coronary artery with inappropriate sinus origin. And in the sportsmen, the most frequently seen coronary anomaly is the interarterial course coronary artery, which is between the aorta and the pulmonary artery. And so to diagnose these coronary anomalies, the coronary CT angiography has a perfect place. In coronary artery bypass patients, to evaluate the bypass vessels, the graft stenosis or reocclusion, the sensitivity and the specificity of the CT angiography is 95%, because the vessels in the graft vessels are diameter are larger. It's easier to evaluate the occlusion or the stenosis. But in the native vessel stenosis or occlusion, because in coronary artery bypass patients, the native arteries are frequently diffusely diseased, it's harder to evaluate the native arteries. But in the graft evaluation, the coronary CT angiography has a great place to evaluate them. And the other popular area that the CT angiography is performed and has some dilemma is coronary stents, because the artifacts is the major problem. But if the stent diameter is over 3 millimeter or it has a thin strut, the diagnostic performance increases. And also because of the diameter, big diameter, the left main stent has clear indication if there are stents in the left main coronary arteries. And so the major concern is the artifacts because of the struts of the stent. But if the diameter is big, or there is thin strut, or if left main stenting, there are the diagnostic performance increases and the indication increases. So in CT angiography, we performed it, and later we get the results, anatomical results, and the quality is important for us. We performed the CT angiography, and we say that yes, there is atherosclerosis here. For example, 40%, 50%, or 60% narrowing, it's soft plaque or calcified plaque. We define the stenosis there inside the vessel. But if there is the atherosclerosis there, is it clinically important or not? We should decide about that. To decide about the atherosclerosis narrowing importance, we should decide about first if there is symptom or not. In case of symptoms, what is the priority? Do we prefer to diagnose their atherosclerosis, or if we don't know whether there is atherosclerosis or not, we should do functional tests such as stress tests or not. So what is our priority? First functional, then anatomic, or first anatomic, then functional evaluation? The approaches change in the recent years because many doctors in the clinics want to know about the atherosclerosis anatomical definition. Because if there is atherosclerosis, we will decide about primary prevention, or we will do invasive coronary angiography or not. If there is anatomically atherosclerosis there, we should decide about if there is functional important narrowing over there or not. So we usually perform stress tests, which is with exercise ECG, or sometimes we can also, if the patient cannot perform an exercise test, we can do scintigraphy for that, if there's ischemia or not. But the other approach is some doctors, if there is symptoms and if the symptoms are stable, for example, chest pain during walking or climbing stairs, then they need to perform stress tests. If there is no functional abnormality, no further need, some doctors don't need to do further anatomical evaluation. So in the recent years, the clinical approaches depend on doctor to doctor, and so what is the priority belongs to every doctor's clinical experience. But myself, and in my clinical practice, I try to perform anatomical. I need to see the anatomical atherosclerosis if the patient is symptomatic, because it's especially in the young patients. I mean, at their ages 40s or 50s, I need to know anatomical atherosclerotic plaques, if they exist or not, if they come to me with complaints of chest pain. And later functional evaluation I try to perform, because it can be life-saving, and especially in the young patients, soft plaques are more common, and it can. I find CT angiography as a life-saving imaging modality. The one other concept is the INOCA, which is ischemia with no obstructive coronary artery disease, and it's a very popular topic in the recent years. And it means that INOCA is under 50% coronary artery stenosis, but the patient complain about chest pains, but the chest pains change time to time. For example, there is 40% or 50% coronary atherosclerosis there, but the patient comes to your clinic and say, I have chest pain, but the other time he or she doesn't complain about chest pain. So it's changing time to time. The chest pain, the symptomatic stage it depends on day to day. And how we approach these INOCA patients. At first year, basal and first year stress tests and symptoms are evaluated. And when there is basal problems, symptoms, or functional abnormalities in the clinic at first year, maybe we find that angina frequency is lower or stress test is normal. But in INOCA patients, the ischemia burden and angina severity has no direct correlation with the narrowing percent. And so there is also this concept that INOCA patients are very new in the clinics because of the new approaches, which I mentioned a few minutes ago. The patients can be documented atherosclerosis, and later when do functional tests, we find a functional abnormality in one visit, but in the other one, we don't find any abnormality in the functional evaluations. So we do medications for these patients, anti-ischemic medications with beta blockers, sometimes nitrates, or the other anti-ischemic medications. So the CT angiography is used frequently in the clinics, and every day in our clinical practice, we perform it with increasing rates in the clinics, and it's very useful, really. And with the performance of the CT angiographies, we can find more life-saving. We can do more life-saving strategies, and so CT angiography is good imaging modality. This is all for today. I can mention you about CT angiography, and wish you good luck. Thank you.
Diyorum. Diğerleri. Başlayabilirsiniz. Ben diğer katılımcıları görebiliyor muyum?
Bir kişi mi var şu an?
Hayır, devam ediyor. Hepsi yok. Sesiniz açık bu arada.
Hı.
Biraz yavaş.
Hello, my name is Hüseyin Aksu. It is a pleasure to meet you. I am an interventional cardiologist. My topic for today is advances in transcatheter aortic valve replacement or implantation. In United States, usually the procedure is called transcatheter aortic valve replacement. In Europe, usually called implantation. I prefer TAVI abbreviation for this procedure. I tried to prepare a general speech about TAVI because I don't know your experience with TAVI. In this overview, will include background, management of aortic stenosis, history of TAVI, current data, planning and procedure, complications, and advances in TAVI. Also, future for TAVI. As you know, aortic stenosis is a narrowing of the aortic valve opening. In etiology of aortic stenosis, especially in developed country, most common cause age-related calcific aortic stenosis or degenerative aortic diseases. Next common cause, rheumatic fever or rheumatic valve disease. Less common causes, congenital abnormalities. Prevalence of severe aortic stenosis increase with age. Over 8 years old age, nearly 10%. With each decade, risk of incidence of aortic stenosis doubles. As age increase, also disease progression is accelerated. For natural history of aortic stenosis, mean velocity increase by 0.3 meter per second for years. Mean gradient increases by 7 millimeter mercury per year. Also, aortic valve area decreases by 0.1 square centimeter per year. Once even mild symptoms develop, prognosis rapidly drops. Event-free survival for severe aortic stenosis, for severe asymptomatic aortic stenosis, 30 to 70% at 2 years. Mortality for symptomatic severe aortic stenosis, nearly 50% at 2 years. Aortic stenosis usually has long latent period, but after onset of angina, average survival is 5 years. After syncope, 3 years. After heart failure symptoms, only 2 years. If we compare this prognosis with other common malignancies, severe inoperable aortic stenosis is the worst one. For therapy of aortic stenosis, medical therapy is not solution because problem is mechanic. This problem solution should be mechanical. No proven effective medical therapy in delaying progression or altering outcome of aortic stenosis. Surgical therapy since 1965 only effective option till TAVI was developed at 2002. Surgical aortic valve replacement for critical aortic stenosis for a long time was only standard therapy by using mechanical tissue or stentless valves. Okay, surgery compared to medical therapy greatly improves survival, but why did a need for TAVI emerge? Because nearly 1/3 of severe aortic stenosis patients in real world are unsuitable for surgery, and these patients, 50% of them die by 2 years. Aortic stenosis patients usually have multiple comorbidities. Also, elderly patients scared or reluctant for surgery, especially after risk counseling. People prefer and demand minimally invasive techniques, local anesthesia, and quick discharge from hospital. In real world, also, as a total, maybe 20% of severe aortic stenosis patients couldn't get enough treatment for aortic stenosis before TAVI. First TAVI in human is performed by Dr. Alain Cribier at 2002 in a patient with cardiogenic shock. After this start, TAVI becomes a pandemic. In first 10 years, maybe 100,000 TAVI is done. Till 2010, several observational studies was done for TAVI. Most of them shows feasibility and benefits of TAVI. Then 2010 clinical trials are started with partner 1 clinical trial at high-risk candidates for surgery. Then for patients not to be suitable candidates for surgery, then also CORVAL clinical trial studied high-risk candidates and inoperable patients. Then clinical trial starts in patients with intermediate risk. Then last clinical trials are were done on low-risk patients. Okay. Meta-analysis of all of these clinical trials showed us TAVI is in mortality better than surgical options, at last in 2 years. As a result, guidelines recommend TAVI procedure for some patients. 2017 American and European guidelines recommended TAVI for high risk and intermediate risk patients, but they also advise heart team and risk stratification. But last month, new ACC guideline is published. In this guideline, TAVI also recommended for high and inop risk patients, but new recommendations are over 70 years old of age patients. TAVI is recommended in preference of surgery. Between 65 to 80 years old of age, both TAVI and surgery recommended. Also, asymptomatic patients with severe aortic stenosis and ejection fraction below 50%, same recommendations were done. There are many types of TAVI devices with different features. For example, expansion methods are different. Balloon expansion, self-expansion, mechanical expansion are possible. Most used one of the most used TAVI system is Edward Sapien system. This evolved during this period. Start with Sapien, Sapien X, then Sapien XT, now Sapien 3 Ultra will come. During this period also technology evolved, sheet size decreased, available valve size are increased also. Another valve system, most used one, core valve system. This system also evolved, decreased sheet size and increased available valve size. Okay, to select patient, what is essential questions? Is valvular heart disease severe? Does the patient have symptoms? Are symptoms related to valvular disease? What are the patient's life expectancy and expected quality of life? Do the expected benefits of intervention outweigh its risk? What are patients' wishes? Are local resources optimal for planned intervention? During patient selection, TAVI or surgery, comorbid indications, surgical risk, patient fragility, and patient preference should be sought. Comorbid conditions, coronary artery disease, chronic obstructive pulmonary disease, cirrhosis, stroke, or TIA history, malignancy, immunodeficiency, or other factors is important. For surgical risk stratification, we use usually Society of Thoracic Surgeon risk score for 30 days, below 4 low, between 4 to 8 intermediate, between 8 to 15 high, more than 15 prohibitive, inoperable patients. Also, patients' benefits should be sought in a special case. For example, females have better survival compared to surgery. Diabetics have significant benefit compared to surgery. Renal dysfunction cause poor outcomes in TAVI surgery, but not for TAVI. Also, major building is decreased in TAVI. Chronic obstructive pulmonary disease patients have better outcomes in TAVI. Also, other valve disease, especially mitral insufficiency, with surgery, mortality is increased, but not in TAVI. The paradigm in TAVI will shift. This can be shown by change of question. At the start, we ask to us, can we do it, or should we do it now? But now we ask ourselves, how should we do it? Pre-TAVI workup. Before TAVI, we should investigate some problems. This workup should include clinic assessment, coronary assessment, annulus assessment by CT, also other relevant cardiac anatomy. Of course, at the end, peripheral arterial system should be investigated. Annulus assessment is important. Why? It is important for planning of the procedure. Transthoracic echocardiography or transesophageal echocardiography are important for determine severity of disease or assess post-procedural results. But for measurement of annulus diameters, not good as computerized tomography. Why? Computerized tomography, usually echocardiography underestimates size. All of these modalities should be used together for patient's situation. Okay. Guideline for computerized tomography imaging in TAVI have many recommendations, but these recommendations include annulus assessment, planning, landing zone classification, valve morphology, heart root measurements, vascular access, coronary arteries, non-cardiac and non-vascular structures evaluation. Okay, I'll show you procedure. Steps of procedure include patient's preparation, venous and arterial access, imaging, rapid ventricular pacing, balloon aortic valvuloplasty, TAVI procedure, and post-procedure assessment. General anesthesia can be preferred according to experience, but conscious sedation and local anesthesia is possible. To start procedure, we need at last two access, venous and arterial access at contralateral leg. In femoral artery, 5 or 6F pigtail catheter for aortic angiography. In femoral vein, for pace lead. At the same site, ipsilateral leg, for TAVI procedure, we need an access by percutaneous way or surgical cut down. After this access provided, delivery sheath insertion is possible. It should be positioned in the descending artery, descending aorta. Then we can start aortic angiography. Ideal projection angle is that native valve is imaged in the perpendicular view, where the valve is seen in profile with all three cusps in line and distinctly visible. This angle is important. This angle is our angle of work. Temporary pacemaker placement. Then a pace lead is placed in the right ventricle. Then we cross aortic valve after anticoagulation. Native aortic valve can be crossed by using unplaster left 1 or 2 catheter and a straight tip guide wire. Then through this catheter, extra stiff guide wire is entered left ventricle. Then catheter withdrawn, but distal wire position should be maintained in the left ventricle. Then we start balloon aortic valvuloplasty under right ventricular pacing at rate 180 to 202 per minute before TAVI or balloon aortic valvuloplasty. But before balloon valvuloplasty, valve prosthesis should be ready because of possibility of hemodynamic instability, development, or severe aortic regurgitation. After this step, valve insertion and deployment is possible. Prosthesis and delivery system inserted in the sheath or extra stiff guide wire. Then after passage of the aortic arch, advanced in ascending aorta. In the same projection as before, perpendicular to screen, aortic annulus, valve is positioned in aortic position. Midline of the stent frame level with aortic annulus level. Appropriate location with angiography, the valve is deployed under right ventricular pacing after below 50 mm mercury systolic pressure is achieved. Balloon inflation should be held 3 or 5 seconds before deflation. Right ventricle pacing then stopped. Right ventricle pacing run generally not last longer than 15 seconds. Then delivery system withdrawn. Then assessment, transvalvular gradient should be measured, and for paravalvular leaks, angiography and echocardiography can be used. Okay, this is a small animation to show you the procedure. This is stiff guide wire inside of the left ventricle. This is balloon for aortic valvuloplasty. Okay, this is TAVI valve. Implantation on balloon. Positioning in native aortic valve. After positioning, inflation of the balloon and placement of the aortic valve. Okay, as all interventional procedure, TAVI has many complications, including stroke, heart block, and arrhythmias, renal dysfunction, severe aortic insufficiency, valve embolization, vascular complications, coronary obstruction. Stroke is the often most feared complication of TAVI. Majority of strokes are ischemic and occur in the first 24 hours of the procedure. Predictors of this problem: new onset of atrial fibrillation, prior stroke, or TIA, balloon post-dilatation, peripheric vascular disease, and aortic atheroma. General incidence is between 2.7 to 5.7%, and increase 1 month mortality 3 or 5-fold. Subclinical cases are more common with MRI screening, but this problem can occur during passage of the valve across aortic arch, during attempt to traverse the aortic valve, during balloon aortic valvuloplasty, during valve implantation. Cerebral embolic protection device during TAVI are evaluated. Meta-analysis of these studies of embolic protection suggests a benefit from their use. These are examples of this protection device. Heart block, another complication. Injury to cardiac conduction system can lead to permanent pacemaker implantation. This problem remains an important limitation for TAVI. The incidence of pacemaker requirements after TAVI is influenced by choice, patient's anatomy, and implant technique. Self-expander or mechanically expandable valve system are linked to higher rates of permanent pacemaker implantation. In recent low-risk trials, requirements of new pacemaker implantation is low in balloon expandable valves. Low implantation depth, valve oversizing, larger valves, and balloon valvuloplasty have all been linked to increased permanent pacemaker requirement. Also, pre-existing right branch bundle block risk factor for complete heart block. Aortic insufficiency, also another problem. It can be valvular or paravalvular. Valvular are more commonly caused by guide wire and disappears once wire is removed. Prosthetic malfunction is rare. Interference with native valve leaflet with prosthetic function is possible but rare. Paravalvular leakage is common. Still, Achilles heels of the TAVI. Despite stepwise improvements in valve design, still problem. Predictive factors for paravalvular leakage are heavy or asymptomatic calcification, valve undersizing, device malpositioning, and incomplete opposition to the native aortic annulus. Surgery has consistently outperformed TAVI for paravalvular leakage in all trials to date. Paravalvular leak after TAVI, at last mild aortic regurgitation, we can see more than 50% of patients, but more than 75% of moderate aortic insufficiency regressed to trivial at 1 year. But this paravalvular leakage is related to worse prognosis. When we see paravalvular leak after immediately the procedure, for balloon expandable valves, valve delivery balloon is typically used with up to 1 or 2 cc add to balloon to oppose valve sealing skirt to annulus. For self-expanded valves, balloon post-dilatation can be performed. Non-responsive to post-dilatation case, maybe paravalvular leakage closure or valve-in-valve procedure can be needed. Okay. This chart show us a prognosis difference between none to trace amount of paravalvular leakage to mild to severe leakage. Okay, another complication, vascular complications after TAVI. Compared to surgery, in TAVI, vascular complications are common. At partner A clinical trial, 18% of TAVI patients have vascular complication. The rate of major vascular complications in TAVI has decreased, but still more than 4% of procedure. This is the result of this improvement, result of improved operator technique, reduced delivery system sheet size, and vascular access closure devices. Early TAVI system required large sheets. Current generation TAVI devices have lower profile delivery system. Slower size also allows transfemoral approach access, more precise valve positioning, and delivery while reducing the risk of major vascular complications. Transfemoral access is preferable to other access methods as it is associated with mortality benefit, shorter hospital stays, and faster recovery. Coronary obstruction is rare complication, usually displaced bulky calcified native leaflet over a coronary ostium, or malpositioning of TAVI is a cause of this complication. Before procedure, height of coronary ostia and dimensions of sinus of valsal valve is evaluated. Ostia should be minimal located 10 mm away from leaflet's insertion. Also, long-term outcomes are important. There are some questions about these issues. For example, patient prosthesis mismatch, durability, coronary access, TAVI after TAVI. But according to last clinical trials, patients' prosthesis mismatch is lower than surgical valve replacement. Nearly 1/3 of rate. For durability, structural valve degeneration also very low in TAVI case. At follow-up, at last through 6 years. Structural valve degeneration also through 6 years better for TAVI. Okay, advances with new generation TAVI valves and imaging. It is possible to easier deployment, better apposition, and less complications, lower profile, retrievable valves, higher durability, and the expansion of the TAVI indications. For future, there are some questions to answer to expand indications. For example, for bicuspid aortic valve, there are observational studies indicate no difference in 1 year all-cause mortality. In superior prosthetic valves, observational studies indicate similar outcomes to Rideau surgery. For aortic regurgitation, multiple small observational studies and ongoing clinical trials, success with use of TAVI is shown. At younger population, observational studies similar or worsened outcomes with TAVI. TAVI or mechanical surgical aortic valve replacement in younger population. For choice, as a choice, we have minimal data. TAVI in end-stage renal disease, observation studies indicate worse outcomes. Moderate aortic stenosis with low ejection fraction and asymptomatic aortic stenosis for TAVI are not studied areas. Comparison of different TAVI valves, we have limited data. Some experience that balloon expandable TAVIs have better outcomes. Thank you for listening. Any question? No question. Thank you again.